Welcome to Willow Lifeline Dialogues, our Code of Life series, where we explore those conversations about science shaping family health today. I'm your host, Dr. Mercy Korir, and this week we delve into sickle cell disease. Globally, over 300,000 children are born with sickle cell disease every year. This is a genetic condition that comes with a lot of challenges, including painful crises, anemia, and attendant infections. Today, we hear Selina Olwanda's story. Through this story, we explore the science, the struggle, and the hope that early diagnosis and management of sickle cell can bring.
One of the most common genetic conditions in Kenya is sickle cell disease. Meet Selina Olwanda, a mother who turned her family's genetic story into a mission to bring hope, awareness, and care to thousands of others.
Sickle cell came to me in the year 1999, and that's when my nephew was diagnosed with sickle cell. I never paid attention to it. It never hit me as anything serious. And so we watched him grow, not understanding what he was going through. Sometimes he'd cry for long hours, but we didn't know that it could have been the pain associated with sickle cell.
Sickle cell disease is caused by a mutation in the genes that control how red blood cells form. When a child inherits two faulty genes, one from each parent, their blood cells take on a sickle shape, breaking down more easily, blocking food, and causing painful crises.
When he was born, he was jaundiced, but the jaundice never went. We did everything, that one of get him out in the sun, and still it wasn't getting over. When he was 6 months, he got vomit and diarrhea, and in the process of that, got really weak. And then when we took him to hospital, they also found out he was anemic. And so they treated him. We were in hospital for some days.
Early signs of sickle cell include persistent anemia, swelling of the hands and feet, yellowing of the eyes, and sudden episodes of pain. Some children may also grow more slowly than their peers. These are the signs that should prompt families to seek testing and care. During one hospital visit, a doctor suggested testing for sickle cell disease based on their family name.
And so, as she was going through the chart, for me, my expectation was discharge. But what came to me was a shock, because then she asked, "What's his surname?" And we said Ogueno. And the minute we mentioned that name, she says, "Test for sickle cell." Now, this didn't come easy. This was not all like for my nephew. This was like, what?
Hassan was then diagnosed with sickle cell disease, a life-changing revelation delivered so casually it left her with more questions than answers. It became a pivotal moment in her journey.
2 weeks later, we went back for a review. He had picked very well. He was eating. There was no more vomit. There was no diarrhea. He was healthy. And the doctor reviewed him. And she let us go. But I still had that pain in my heart. Why did they ask for his surname, then test for sickle cell? And that thing was biting me so hard. So when she didn't mention it, I said, "By the way, you tested for sickle cell. What did you find?" And she's like, "Oh, I forgot," and went back to his file. This was not all like for my nephew. This was like, what?
Hassan was then diagnosed with sickle cell disease, a life-changing revelation delivered so casually it left her with more questions than answers. It became a pivotal moment in her journey.
2 weeks later, we went back for a review. He had picked very well. He was eating. There was no more vomit. There was no diarrhea. He was healthy. And the doctor reviewed him. And she let us go. But I still had that pain in my heart. Why did they ask for his surname, then test for sickle cell? And that thing was biting me so hard. So when she didn't mention it, I said, by the way, you tested for sickle cell. What did you find? And she's like, oh, I forgot, and went back to his file.
To a family history that had never been openly discussed. She now believes families should talk freely about sickle cell rather than let silence and stigma persist.
And so one time when now I was learning more about sickle cell, I got to sit with my mother and I started asking about our family history. And I learned a lot from her, and mostly a lot about my father's side, because we eventually got to do screening for all of us, and we now know our statuses, and I'm happy to say that my mother has 2 normal genes, so she was not the source of our sickle cell in the family. But that said, it doesn't mean that actually the saving grace was that my father was a carrier, my mother had 2 normal genes, and that actually made it very easy for us. We never saw sickle cell.
Out of the commitment to meet her grandchildren, she was referred by her doctor to join Children's Sickle Cell Foundation, a support system for families and a voice for advocacy.
And so, going to this hospital, meeting Dr. Afula, learning about sickle cell, and him introducing me to Children's Sickle Cell Foundation changed my life, and changed my life for the better, because then now I got to learn about sickle cell disease.
Screening is simple. It's just a blood test. But Selina says it must go together with genetic counseling so couples can make informed choices about their future.
It's nothing that we should fear. Just some little blood taken, and then it's screened and your results come. But then the other thing is that people have to be counseled, because I told you about how my diagnosis was done. And your son has sickle cell disease. That should not be how you break it. It should be a place where you first find out what knowledge that this person have, and to what extent do they understand sickle cell. Genetic counseling is one of the things that's lacking in this country.
In schools, fatigue is mistaken for laziness. At work, ability is overshadowed by the condition. Stigma adds another layer of pain.
That this child is slightly special in this way and that way. They may have to take a little bit more fluids. They may have to go to the toilet regularly. They may sometimes be very tired to even go on with the classes. They may miss school, and they may fall sick suddenly. Many schools, when they are not prepared for that, they tend to think that the child is malingering. We need to talk to employers that if they have people living with sickle cell, one of the things they need to do is have faith that they will deliver. Not look at the disease and decide that that's what they've employed. Employ the person, not the disease.
The journey is demanding, from the daily cost of medicine to regular hospital visits to sudden crises that require urgent blood transfusions. For caregivers, the wait is constant and unrelenting.
You have to adjust your lifestyle to a place where you're always battling between bills, and this person pays tax like any other person. Their caregivers are also burdened. Imagine a caregiver with more than 1 child. 1 child already is a burden. You're expected that the much you make, you still have to pay taxes and still have to be with these children in hospital. Sometimes you're in hospital more than you're at work. So many of them are not even formally employed. They hustle day and night.
Resilience to Selina is a thread that runs through every family she meets.
My son is my example, but my biggest experience is the community I work with. They have taught me to be resilient. They have taught me that love is nothing you can negotiate. You either give it or you don't. And they've also taught me that if people come together, they get to achieve a lot.
Her hope is for a Kenya where genetics is no longer a mystery. Newborn screening has begun, a step in the right direction, but Selina believes it must go further.
I encourage people within the community to start talking about sickle cell freely. There's no branding. Let's just find out, do I have the gene or not? And let's not try and regionalize it, because unfortunately, Kenya is a country that has sickle cell disease. So everybody is a target. Get to know your status first before you can even start saying anything. And once you understand your status, make informed choices.
With early screening, stronger health system and family support, families like Selina's show that the future can be different. Genes may set the stage, but it is knowledge and community that decide the future. For Code of Life, I am Sarah Kamande.
And to help us make sense of this story and others is Dr. Catherine Mutinda, who is a pediatrician and geneticist who works with families and couples across Kenya to understand inherited conditions like sickle cell disease, children's developmental challenges, and the tough choices that sometimes come with knowing more about our genes. Karibu sana daktari, as always, it's a pleasure to have you on the show.
Thank you.
Now, for somebody who may be hearing sickle cell disease for the first time, how do you explain it?
Wow. I guess it's because it's a prototype in a lot of medical schools.
Yes.
But sickle cell disease is a disease that affects the oxygen carrying capacity of your blood. And specifically, the part of your blood that carries the oxygen is the red blood cells. So their capacity to carry oxygen. Now, normally, if you have low oxygen in the atmosphere, what our bodies do is increase the amount of red blood cells, and that's how we know our sportsmen are running much faster. But for someone who has sickle cell, when there's a low amount of oxygen in the air, what they do is their red blood cells, they sickle. So they become smaller, like the sickle that we were taught in agriculture.
Yeah, C-shaped.
C-shaped, the one for cutting wheat, and yes, they start looking like that, meaning there's less area for the cell to carry oxygen. Yes. So not only during areas of low oxygen, but basically during stress situations, like an infection, dehydration, they sickle. So the oxygen carry capacity of the cell is reduced.
Why do these children have so many hospital admissions?
Because number one, once the cell sickles, it gets entrapped in the small vessels. So that entrapment causes them to be in pain. That's the painful crisis. So because it has entrapped that area, it means also oxygen is not reaching that area, nutrients are not reaching that area, and of course, the subsequent things include pain. The first thing you see in children, they get swelling. And then after that, because of these sickled cells, they're going to be entrapped in an organ called the spleen. So the spleen entraps so many of them that the spleen gets very big. And eventually it involutes itself because it can't manage. So those are the painful crises that keep the patients coming. Infections keep the patient coming. That's why they're always in hospital. And then the low amount of red blood cells in the body because of early death of the red blood cells. So they come in with anemia. So they have to be transfused often. Yes.
Okay, and we'll come to management and how to cope for families. But looking into genetics, how is it passed from the parents to the children? And is there a risk of all children getting sickle cell disease?
Sickle cell disease is the classic, one of the classic Mendelian diseases. We call it autosomal recessive, meaning for a child who has sickle cell disease, the parents are carriers. Carriers do not show the disease, they just carry it and pass it.
So is it one parent or both parents need to be carriers?
Both parents need to be carriers for them to have an autosomal recessive disease. That is sickle cell. So mom is carrying, dad is carrying. And then on top of that carriage, they only have a 25% chance of having a sickle cell disease child. Otherwise, they have a 50% chance of reproducing carriers like themselves and a 25% chance of producing children who are totally unaffected by that gene. So we say 75% are unaffected, 25% affected.
So if they have 4 children, then it means 1 can have the disease,
Yes.
2 can be carriers, and 1 will be
Totally
okay.
unaffected.
Not a carrier, not having the disease. Totally
Exactly.
Okay.
So that's what we describe genotype, phenotype. So the genotype is what you have said. Phenotypically, we say 75% then are unaffected because we don't see the disease in the carrier state and in the unaffected.
Okay. Why do we see this disease in certain parts of Kenya, like Western Nyanza region, and certain parts of Africa?
And the coast region Region, yes. So there's something called founder mutations. So as we said earlier, or maybe you said in other episodes, we are not photocopies of each other. So as we reproduce and we transmit our genes, we are trying to be better for the environment we are in. If you look at the areas within which sickle cell is, these are malaria-prone regions. And malaria, the parasite, attacks the red blood cells. So a sickled cell is harder for the parasite to get into. So it was one of the adaptive mechanisms nature presented for the human race to survive near the rainforest, near areas with mosquitoes. However, in its hemizygous state, that means that heterozygous state, that means that one allele is affected and the other one is not affected, then the patient is immune or does not get a lot of severe malaria. In its homozygous state, that is the disease state, then the child has the disease, now then it has all these other problems. So the founder mutations around these areas are where we find the disease more prone. So it's not tribal, it's just the area within which historically the communities were sitting.
So is a child or a person who's a carrier also protected from malaria?
Most of the time, yes.
Most of the time. Okay, all right. It is because most places, or rather we've had stories of people saying, certain people could be their cursed, they're bewitched, so you need to move them away from that region because, there's that malaria sickle cell connection.
Yes.
Yeah.
So I don't think it's, even though you move them, you don't change their genes. So they move with their genes. So, and that's why I said it's not tribal, because before it was very easy to say, oh, you're from the Western Nyanza area or you're from the coast region, Voi, therefore we will check for malaria. But we also have Kamaus who have malaria. Why? Because we moved. We moved, we intermarry, and the genes don't lie.
Yeah.
So you find my mom is Wangoi, and Wangoi comes to town and meets Otieno. And Wangoi is also a carrier, and so is Otieno. So if you are to go with the myth, it's no longer holding water currently. But because people move, they don't leave their genes behind, they move with them.
With their genes.
Yes.
Okay. At what point would it be most ideal to make a diagnosis of sickle cell disease?
At birth. At birth. And I must say at this point, there's a big project that's running in the western area of Kenya, Nyanza, Kisumu, the former Nyanza province, Kakamega, where we have dry blood spot diagnosis of sickle cell. It's important to retain the dry blood spot. It's easy to do. During the HIV pandemic, all babies who were born of mothers who are positive had a dry blood spot taken. It's the same procedure even for these children. They just have a dry blood spot taken and then a test is done and then the diagnosis is made. The earlier, the better. Because now once the parents know this is a sickle cell, not carrier, but the one who's affected, then they can start prophylactic medication, like for example, hydroxyurea, that helps maintain the fetal HB, which should actually the body should get rid of it. But if you keep the baby on hydroxyurea, the fetal HB retains, which is good for the child who is a sickler. So they can start hydroxyurea, they can start prophylactic medication, antibiotics for themselves. We can keep them well hydrated to avoid dactylitis and postpone as much as possible the first crisis and the first transfusion. Improve on the quality of life.
So say the diagnosis is not made early enough, even at birth. What would be the first or the early signs and symptoms that this child may have sickle cell disease?
So the first time at around between 4 to 6 months, this child will start coming into hospital more often with infections. Yeah, so a lot of homas, infection. And then the one that actually sells the disease is the swelling. The feet are swollen, the fingers are swollen, they're in a lot of pain, so they are crying a lot. They are crying a lot, and once they get to hospital and you have to do a lot of pain medication, hydrate, the swelling goes down. So that's the first thing that patients come in with. And then when you do the lab tests, the HB is down, usually below 9. So that's the first time now the healthcare providers start getting hints that there is something going on here. Yes.
Kenya having high prevalence of sickle cell disease, shouldn't high index of suspicion be part of healthcare workers, the nurses, the doctors at birth to know or ask basic questions or even do newborn screening for sickle cell disease routinely?
Wow, my dream, and I think if I die today and newborn screening is being done in Kenya, I will die a very comfortable Kenyan. My dream is to have not only newborn screening for sickle cell, but for a couple of other things that we will talk about. But newborn screening is really key, especially in an area like ours, where we know it's very prevalent. So it will be the best thing that can ever happen in our country, in our health system, if we introduce newborn screening.
What does it take to do that newborn screening?
Just a dry blood spot. That's it. That's at the healthcare provision point of at the clinical level. A dry blood spot sample can be put in an envelope and be stored for ages. So once we collect for every baby born in Kenya, if today someone were to decree, every baby born in Kenya will have a dry blood spot. And then we have a reference lab, and we have maybe, let's take sickle cell, for example, as one of the things that we are checking. So we will actually test all these dry blood spots, and the positive ones, we will transmit that information in the 6-week visit. In fact, we shouldn't change much. The mother is coming back to hospital for the vaccines at 6 weeks. We can transmit that information at that point and tell them, oh, by the way, we did this and we found that this baby is affected, and therefore your care provision will look like this. At that point, the health savings, the cost savings that you have done, the quality of life that you have improved for that child is enormous. You will not have to admit this child, at least in the first year of life. However, if we continue the way we are continuing, we're going to waste a lot of time in hospital.
How much is that dry blood spot or that to make that diagnosis at that point? How much is it?
Wow, if you look at it from a mass point of view, it should come to a few cents per patient if you are doing it in volume. But the individual testing can cost a lot if you're doing it one person at a time, because it's electrophoresis. So with electrophoresis, the machine requires you to load it, a minimum of 96 samples. So you can imagine, if I'm going to run the machine for one sample, they're going to pay for the other 95.
Yeah.
But if I have 95 samples, all of them are doing with the same reagents, the cost just drops down. Yes. So, and we don't want, if we were to go for a national screening program, I would advocate for it not only to be only sickle cell, but load everything else. That's why I'm saying a dry blood spot is the best way to go, because with a dry blood spot, the sample is good for inborn errors of immunity, inborn errors of metabolism. Anything you want us to check, we will check.
We'll check
with just that one. We just have to agree which ones are we going to test, because we can't test everything. But they are the ones that, like for example, sickle cell. is prevalent in our country, we should put it up there. We should have a case for it. Yes.
You said earlier that the children would start showing up in and out of hospital from 4 to 6 months.
4 to 6 months.
Does it mean before then they are otherwise okay and normal
They
babies?
seemingly are otherwise okay because you have types of HBs in our body. There's the fetal HB. The fetal HB type is the one that is more prevalent in the baby than born child. Why? It is able to live with low amounts of oxygen in the womb. So they have a fetal HB. As you transit from the fetal HB, you come to the adult HB, which all of us have who do not have sickle cell. However, the ones who have sickle cell, they have HBSS. Yeah? So they lose the fetal portion. If they lose the fetal portion, you see now their oxygen carrying capacity is actually lowered. The fetal DNA has a very high oxygen carrying capacity. And why 3 months? That's the lifespan of a red blood cell. When it's 3 months, we rejuvenate. So we start seeing them at around 4 months because now the new ones, if you're losing the fetal HB, we start seeing them that early. Yes.
Okay, so it would be important to have the diagnosis before the 3rd, 4th month of life. Is there a role for genetic testing even before conception?
Yes. So sickle cell is not a one change, DNA change for everything. So you can be a sickler because of the most common one is a single nucleotide variation, a change. But you can also have a deletion in the HBB gene that can cause also sickle cell. Now, if you have parents who are sicklers, both of them, they know they are carriers of the disease, and they come before they have a child, then you can actually diagnose the unborn child. So the unborn child can be diagnosed with something called karyotype sequencing. Interesting, right?
Yeah.
No longer NIPT. NIPT is for big stuff. Karyoseq is a new method where we are taking actually the embryo's DNA and sequencing it. So we are able to actually diagnose the small, finite genetic disorders. So that's in utero. At birth, we have already discussed it. Yeah. So genetic testing also opens the door for genetic management, for gene editing. And I think a lot of people know that. I think now it's coming to 4 years ago. The Nobel Peace Prize for Science was on gene editing, the CRISPR model. So the CRISPR model as a treatment, not management, treatment modality for sickle cell is actually correcting the single nucleotide change that happens in sicklers. It's treatment, not management. Treatment. Gene editing, you edit, you remove the bad, you put the good, and everything goes well. Yes.
So does it go well for the person who has a disease
It goes
now
well.
only, or can that be,
No, only for that person.
Can it be transmitted to
The person is already a sickle cell disease person. So genotypically, in his gametes, he can transmit sickle cell, or she can transmit sickle cell. If she were to meet a person who is not a sickle cell carrier, they would only have carriers for their babies. But if he were to meet, or she was to meet a person who was a sickle cell carrier, and he was a diseased person, 50% of their children have sickle cell disease now. You understand? So there's a difference. Gene editing is only ethically permissible in somatic mutations. We are not correcting germline mutations.
So somatic is whatever is already
What I can see,
what is presented
what is
already.
presented. So we are not going to change what is in basic language. You're not changing what is in the sperm and in the ovaries. We are not changing that. We're changing what is circulating. Yes.
Okay. And so that's the genetic testing bit, the genetic counseling, because there are some countries where, before a couple gets married, for example, they have to check if you're a carrier of a certain disease, and if both of you are carriers, then you're not allowed.
Correct.
Are we there yet, or what are we doing with our genetic counseling as a country?
We are not there yet, but I wish we were going to get there already. I love Gen X generation, they are getting there. They are faster than the rest of us. They are coming on very quickly. Gen Zs
Gen
are
Zs.
coming. The millennials are coming in because they are realizing they can actually avoid these things. A close cousin to sickle cell disease is thalassemia, and thalassemia is very prevalent in the Arab world, and that is where that is practiced a lot. I think in Kenya we cannot legislate the heart, but we can actually work towards protecting the health system and the few resources that we have by encouraging people to have this checked. Because apart from genetic testing for sickle cell, there's also the biochemical testing, which is very widely available. Can you do, I think it's called, there's liquid chromatography, which is actually part of the screening, and then there's a sickling test, although not a very good test, but it's a good test, especially if it's accessible to a lot of patients. You can actually have that checked. Yeah, very good places to start.
And I so say a couple comes and they're both carriers, and there's risk of 25% chance of getting a child who's a sickler. What would that conversation between yourself and this
them
couple
look like?
like?
As I said at the beginning of everything, what do they want? They want to have a child. How far or how much do they want us to invade their reproductive health? So if they are hell-bent on perfection, then we will be talking about pre-implantation genetics. Before we implant the embryo, we'll have to have that discussion. If they are open to us testing the embryo already in the mother's uterus, as I said, we can also do that. And we can also now also invoke the fact that we can test after delivery. So they have all these options. It's a question of where do they come in and what do they want. A lot of the patients I see is when they've already had a child who's already affected. Before then, they didn't know, or they thought they knew, but they didn't think that it would affect them. Maybe a sister was affected, but they thought that was just for the sister, but not themselves.
Yeah.
But when it affects them, that's when they start thinking again. But once the affected child has already arrived, the risk now moves from 25% to around 37% in the subsequent pregnancy. So as the child who is a sickler or the recessive gene shows up, the risk
Goes up.
So if you have two sicklers, the chances of a third one
Is
is
even
higher. Yeah. So it's only when they meet the first child that's when they seem to come. Yeah.
There are many myths and misconceptions around sickle cell disease. Some people think it's a curse, it's a punishment for something. How do you address this with these families?
We have to start from what do they understand? Because apart from those myths about them being curses, there's also that thing of saying the woman is to blame, or it's not from our side of the family, it's from that side of the family. So the first place we start is educating this couple that if there's anything like Ikituni 50-50, sickle cell is Ikituni 50-50. A lot of work is going on in the communities, especially in the Western Kenya and in Nyanza, with a lot of educators, sickle cell educators, to talk to people and tell them, by the way, this thing is not uchawi. It is actually, this is what's going on, and that's how so and so and so and so have this baby, because they are carriers. And because it's such a practical disease to see, practical in that you can tell these parents of the sickler hardly ever get malaria. So it's very practical to actually explain and now tell them, okay, now you can see the HB has gone down. That's why we're adding more blood. And we're adding more blood because the HbS has a long half-life. So you are able, it's very practical and they can see it. If they take care of the child very well, they can see the child growing and without problems. So the fact that it's a very practical disease makes it easier to communicate. A lot of the time, and that was in the past, a lot of the time people used to avoid telling bad news about sickle cell to the parents. But nowadays it's becoming more acceptable because parents are opening up to saying, okay, one of my children is a sickler, so we go for this clinic. So they are able to verbalize, so that is helping.
Okay. You talked in treatment and management, you talked earlier about gene editing. Are there other treatment modalities that are available, especially those available locally or already being done locally?
So let's start. Treatment for sickle cell disease currently is gene editing treatment. The rest is management. Yes. So management, number one is hydroxyurea. In the past, I was the National Secretary for Kenya Pediatric Association. We did a lot of work, and now hydroxyurea syrup is available. So our babies can have the syrup. Before it was a tablet that they had to crush. Now the syrup is there, so we are very happy. So hydroxyurea is there. It will support the fetal HB2 stay. There's antibiotic prophylaxis already available. Vaccine, the pneumococcal, meningococcal vaccines are available. Now, those are already mainstream available. Now, let's go to the clinical trials. Pyruvate kinase is a molecule that is being studied in clinical trials, that it helps improve the oxygen carrying capacity of the sickled red blood cell. There are already stage 4 clinical trials locally that are already getting patients in. There are some that have closed, and they have very good results. Some have tried other molecules that have not worked very well, and they have stopped the clinical trials. So those are a few of the molecules that are available. So you can see everybody's just trying to improve the oxygen carrying capacity of the sickle cell. So the final part, so we've managed with what is mainstream and then clinical trials. The final part is plasmapheresis, complete exchange of your red blood cells for healthy blood cells. That is actually still done. Yeah, but you see, it's a total exchange, and these patients have to come in every 2 to 3 months for that plasma exchange.
Oh, it's not like
it's not one-off. No. We've already established treatment ni gene editing. The rest is management.
Yeah.
Yes, but very good outcomes. Very good. Before, people used to say, "Oh, all sicklers will die by teenagehood." Now we're seeing adults. So management is working as well.
Management is working. And in terms of coping on a day-to-day basis, what should parents do so that they can avoid frequent hospitalizations, the painful crisis? What are some of the things that they can do within their home environment, within the school environment, for these children to have an improved and better quality of life?
So we had already started saying any stressor will get the cell sickled. So one of the biggest stressors is dehydration. So hydrate.
Take a lot of water.
Take a lot of water. Make sure your child is well hydrated. Any infection, catch it early, treat it early. The good thing with most of our sicklers, once they are diagnosed, they are also put on a prophylactic antibiotic, which also helps them overcome some of the childhood disorders. So it is important to remember, once the mother is very well educated, she doesn't keep the information to herself. She goes, talks to the teacher. The child is going to school and say, "Oh, my boy XYZ has sickle cell disease." If they're going out for PE, ensure he's taken at least a little of water. And when they come from PE, push him to take another little of water, so that we don't get into a painful crisis when he comes home. If he looks a little bit wobbly, a bit of fever, hydrate him, give him his paracetamol. But because he has a high propensity of infection, don't waste time asking, "Oh, we are waiting." No, just let me know, and then I can come take the baby. Make sure they are treated promptly. That way they don't miss school. They work very well. I mean, it's a community
They
thing.
have an improved quality of life.
Yeah, when everybody is involved. Yes.
Okay. If you had, and I think I'm almost preempting this, but I'll ask, if you had the opportunity to make one policy change in the country in regards to sickle cell disease, what would that be?
All babies should be screened at birth. Everybody should be. All babies should be screened at birth for sickle cell.
All the 1.2 million births in Kenya.
1.2 million, and I think it is doable. It is possible, and it will avert a lot of problems. If it was then within my purview, I'm allowed a little bit of grace, I would say all couples going into marriage should check their status as well. So
Sickle
that,
cell.
yeah, for sickle cell. But policy-wise, all babies need to be screened, all of them. It shouldn't be like right now, it's actually a project. It shouldn't be a project. It should be a government initiative, because it's government that has to take care of us when we need that transfusion. Those transfusion drives, all those, we need to just say as government, we are not willing to lose time with patients or babies in hospitals, or even parents crying. Let us screen all of them. Let us manage all of them.
We know
as we wait for the prices of gene editing to come down, we can be doing the management that is available.
And it's not even just children being hospitalized. That means there's someone's productivity being affected because they have to take time off work, time off they would have.
You admit the mother, you admit the baby.
Yeah.
And then the father is pseudo-admitted because he has to come visit.
Yeah.
So he has to leave work early to PTR.
So we actually lose more from not getting this early. All right. Thank you. Thank you so much, Dr. for talking to us about sickle cell, shedding some light on, sickle cell disease, what families go through, and, what families can do, what people can do to get to know about sickle cell and manage it, and the new developments that are happening around sickle cell disease. So thank you very much for watching and listening to Willow Health Media, our Code of Life series. If this episode has touched you in any way, please share it with your colleagues, your friends and family, and follow us on our YouTube, Spotify channels, and any of our social media channels at Willow Health Media. We continue having these conversations where science and stories impact and influence everyday health. I'm Dr. Masi Korir. Until next time, stay well, stay empowered, stay healthy.